Welcome, everyone. The American Association of Neurological Surgeons is accredited by the Accreditation Council for Continuing Medical Education to provide medical education for physicians. The AANS designates this live activity for a maximum of 1 AMA PRA Category 1 credit. As a provider accredited by the Accreditation Council for Continuing Medical Education, the AANS must ensure balance, independence, objectivity, and scientific rigor in all its sponsored educational activities. In accordance with the ACCME's standards for integrity and independence in accredited education, the AANS is required to disclose to the activity audience the relevant financial relationships of the planners, faculty, and any other individual in a position to control content of this activity. Those who have disclosed a relationship with ineligible companies are listed on the current slide. All disclosed financial relationships have been mitigated in accordance with the ACCME standards. Planners, faculty, and any other individuals in control of content not listed have indicated they have no relevant financial relationships or conflicts of interest to disclose for this activity. Credit claiming will be available in our learning management system, NeuroU. Claiming instructions are on the screen and will be shared again at the conclusion of this webinar. By the end of this week, participants will receive an email notification of enrollment to claim credit. This notification email will also include the instructions on screen for your convenience. For any issues or questions regarding claiming credit, please contact education@aans.org. Now to get us started, I would like to introduce Dr. Hadjipanayas.
Thank you, Tim. Welcome, everybody. I'm Kostas Hadjipanayas. On behalf of the AANS CNS tumor section, I'm happy to introduce Dr. Richard Byrne, who will get a more formal introduction by Dr. Maria Newell Ulhuda to our series today. These webinars have become an important part of our educational mission for the tumor section. They are all recorded for free to be viewed at your leisure on our tumor section website. Dr. Byrne is a friend and colleague of mine and an expert in mapping. And we couldn't think of a better speaker for our mapping series today than Rich. So Dr. Newell Ulhuda will provide more of an introduction for Rich Byrne. Thank you very much for joining us today.
Thank you very much, sir. It's an honor to introduce Professor Richard Byrne. He's the department chair of the Department of Neurological Surgery at the Mayo Clinic in Florida. He has previously served for 18 years as the chair of the Department of Neurological Surgery at the Rush University. Dr. Byrne has served some major leadership roles, including the president of Neurological Society of America, the director of the American Board of Neurological Surgeons, the board of directors of the American Association of Neurological Surgeons, and the board of directors of the Congress of Neurological Surgery, and lastly, the president-elect for the Society of Neurological Surgeons. He has been really renowned for his, impeccable grip on the topic of brain mapping. And he has published a lot of prolific papers, which most of us have already read and know about. So it's a real honor to welcome him today for our webinar series. Professor Richard Byrne, thank you very much for joining us today and for sparing time from your very busy schedule. It's an honor to welcome you. The podium is all yours now.
Right. Thank you very much, Maria. Thank you, Kostas, and thanks to the Executive Committee of the Tumor Section. It's an honor to be here. I'm happy to talk about my experience in cortical stimulation mapping for glioma specifically. I'm going to be sharing some of my experience. I have my personal ideas and biases about certain things. I'll share them with you, and I'll try to keep it as literature-based as possible in an area that could use some more study, in my opinion. So I'm going to share my screen here. Hopefully you're all going to be able to see it. Let's see. All right, can everyone see?
Looks good. Yes, we can.
Okay. And you can hear me well?
Yes.
Yes, sir.
All right, great. All right, so I'm going to be really talking in more of an introductory way. I realize that there are probably some experts in mapping out there. I hope you'll learn something from what I'm talking about, particularly some of the technical things that I've thought through pretty deeply. But for those of you who are just getting an introduction to this, I think you'll find this useful as well. So let's see if I can get this to move. Yeah, here we go. My disclosures, I have no conflicts of interest with industry. And just by way of outline, I'm going to talk about some of the early history. Some folks won't know this, but it's pretty interesting stuff. And I'm going to talk about when is mapping needed and not needed. I'm not a mapping absolutist. I do believe in selective mapping. And I'm going to talk over some technical issues that I think are not as well understood as they might be, and I'll give you some case illustrations. So it turns out that mapping is really at the intersection of two parts of my career. I've been doing brain tumors for 28 years. I've also been doing epilepsy surgery for that long. And I've done about 350 amygdala hippocampectomies. I've done hemispherectomies and so on. Epilepsy surgery is part of my practice and my passion as well. And there's a lot of overlap between cortical stimulation mapping for glioma and in epilepsy surgery. You're really looking for function, one to stay away from it, and the other one you're looking for brain circuitry for epilepsy. And there is a common theme that's emerging, and that is that white matter matters. There's no such thing as a speech area. There's really speech circuits. And we're understanding that more the more we look at things like connectomes and do more detailed mapping studies. And, despite the fact that we've come a long way in neurosurgery, and, that's an instrument tray from 100 years ago, and now we have all of these tools that are disposable. We've got all of these tools where I'm practicing now. We are still limited so much, as Percival Bailey said almost 100 years ago. With glioma, it's obvious that any surgical attack must be radical. The surgeon must cut high, wide, and handsome, and is immediately checked by the realization of the results of such a procedure. That's very, very true, not just for cortical areas, for subcortical areas, connections, blood vessels, etc. And that's why we need mapping. So cortical stimulation mapping is not a new technique, it's an old technique revisited. This is Wilder Penfield and Wilder Penfield's operating room. As far as mapping goes and awake surgery, this is the awake surgery protocol from the 1930s at my old institution, Rush. This is Adrian Verbruggen, who trained at Mayo Clinic and then was doing awake surgery 100 years ago. And this is Percival Bailey, who we just saw that quote from. Percival Bailey started the epilepsy surgery program at the University of Illinois Neuropsych Institute, which was down the street from Rush. He was on the medical staff of both. And there he is doing awake EEG mapping for epilepsy surgery. And this is a paper from 1951. So my training really came out of this group, which was one of the early mapping centers on the west side of Chicago, and why I wanted to be there. So how about with glioma? So what's the clinical problem? The clinical problem is really that gliomas infiltrate normal brain. It's difficult to determine its edges. And that's not true really of metastasis, cavernous malformations, or AVMs, where I use a lot less mapping. Image guidance loses its accuracy with decompression. All of the SSEPs, MEPs have false positives. There's delays, etc. There is no live monitoring system for speech, and essential speech circuits are variable in location. And then finally, resecting the tumor-brain interface is the highest risk part of the operation. Taking out the center of the tumor is not particularly risky. It's all about the edges. So when you think about volumetric resection, that's what we're talking about with glioma in order to make a difference in glioma outcome. And you think about the circumference of a sphere, and not all of them are spherical, but we'll just use this as an example. It's 4 pi r squared. So we're talking about the radius really matters, and the circumference is a square of the radius. So as the tumor grows, more and more areas are impacted, and the volume of the tumor is 4/3 pi r cubed. So the volume is even more related to the radius. So if you want to get a volumetric resection, you really do have to get to the edges. And I use this case an example from 20 years ago. This is a young attorney in Chicago, and she had this very large, low-grade tumor. She's developing early hydrocephalus. You really have to get a lot done here. You can't just do an internal debulking. I could not convince her to do awake surgery with mapping. In the end, when we opened up, it turned out that the tumor looked a lot like normal brain, not like what you would expect from the scan, but a lot like normal brain. I was able to get a debulking procedure done, woke her up, convinced her to have an awake procedure done a few weeks later, and with the awake mapping technique was able to get this done. And then here was her scan about 15 years after that procedure. So you see the impact of doing an aggressive operation is I can't be sure that my surgery did all this. Some of the chemotherapy she had afterwards may have had a strong impact, but clearly we got her through the operation safely. She's still practicing as an attorney. So just debulking typically won't get it done. You really do have to go for the edges of the tumor in order to make a big impact. So in surgery, we have the options of no surgery, biopsy, radiosurgery, lit, and craniotomy for resection. We have these adjuncts: functional imaging, 5-ALA, ultrasound, IMRI, and stimulation mapping. I've used all of them. And there are times to use one versus the other. A lot of them you can use together. And then finally, we have stimulation mapping and awake surgery, which I still lean on a lot, is really in my go-to and gold standard, because I know exactly what's going on, particularly with speech. You know, when you're talking about speech, we're done a service by Broca in describing his classic patients, Laborgne and Lalonde, but a little bit of a disservice when it's described as Broca's area. I think Broca knew that it was more than just an area. There was more going on than just the inferior posterior portion of the left frontal lobe. If you look at the original strokes here, they involved the inferior posterior left frontal lobe, but also a portion of the low central area, the precentral gyrus, a little bit of the insula, the temporal lobe. And then when you do MRI on these subjects, which was done by Nina Dronkers and her team, it turns out there was a lot of white matter injury as well. So SLF3 was really injured here for these patients that were significantly dysphasic. So you have to understand, it's not an area, it's really more a circuit. And looking at this work that I did with a team at the University of Chicago, when you look at what happens over time and you put grids in these patients, you give them a tone, they hear a word, and then there's a response. All of this takes time, and you see it spreading through the dorsal stream and the ventral stream. We share the ventral stream with other primates, and the dorsal stream is fairly unique to humans. So there's a lot going on with speech, and there's a lot of areas involved. Not all are essential. So functional imaging is useful. I use functional imaging at times. There are times, however, when if I know I'm going to do it awake with mapping, functional imaging is interesting to look at. It's pretty and so on. But if I already know I'm going to do it awake with mapping, I just go ahead and do so. This is the way we think it through, or at least that I think it through. Once a tumor has been identified, you can take a look at this paper. It's fairly detailed, but the bottom line is the closer it is to eloquent cortex and the more cooperative a patient we have, if we don't have contraindications, I tend to do it awake with mapping. Sometimes we'll do it otherwise. Sometimes motor mapping with the patient asleep is also appropriate. So when should we do mapping for eloquent area tumors? In my opinion, the indications are when a brain mapping is appropriate when there's focal appearing tumors. So in other words, the case on the left, not the case on the right. The case on the right is a biopsy case. You see it's spread through the brainstem, where the tumor may overlap speech, motor, or sensory cortex, or their subcortical tracts, and surgery may put them at risk. So in my opinion, mapping is not necessary if the borders are very clear and the surgical approach does not disrupt eloquent cortex. So this is a case of a patient with a large cavernous malformation in the insula and the anterior frontal lobe, dominant hemisphere. This is not a mapping case to me. This is straightforward transsylvian resection. The borders are abundantly clear. You don't really have a question where the lesion ends. The lesion is very, very clear. Also, if there's an alternate way that doesn't put eloquent cortex at risk, then I'll go with it. In a case like this, where Lebet is very, very posterior, you can go subtemporal to get to this tumor without putting speech areas at risk. Or this is a case from 2 weeks ago. When you see a case like this, the person's somewhat dysphasic. This is a recurrent tumor. It was called a glioblastoma at the outside institution. It looked very unusual to me. I opted to do this case asleep. I didn't need to map it per se, because in reality, the limiting step in this operation is going to be the entanglement of the middle cerebral arteries here. It's not really borders of eloquent cortex. What you're going to end up having to do is take the tumor out, preserving those arteries, and not worrying quite so much of the back border, because the tumor is very, very different from normal looking brain. So you can get an operation done like that, where you preserve those arteries and don't put the patient's speech areas really at risk. So other indication is when there's maximal resection may reduce symptoms. This is particularly true with mass effect or seizures. As far as mass effect goes, I mean, some cases are very, very obvious. You see the mass effect here with this patient with headaches, confusion, and a seizure. Here we are intra-op. And I'm doing a sleep motor mapping along the way. In this case, you can see we've identified very clearly the precentral gyrus. You can see the tumor swelling out in that left frontal lobe, and you can see the resection cavity at the end, and an intact patient afterwards. So this is, you can get all this done simply with a sleep stimulation motor mapping for the descending white matter area. This case, in my opinion, would be too dangerous to do awake. You can see intense amounts of mass effect. This person awake, you really wouldn't have control over the airway. If they had a seizure, it'd be very, very dangerous. And the patient is confused and disoriented and would really not going to be able to follow commands or follow an exam very well. This is a recent paper that we just put out of Mayo Clinic, Florida here. I'm not even sure if it's published yet. And you know, if you can get the patient through and preserve their Karnofsky performance score, whether it's glioblastoma or low-grade glioma, they're far more likely to return to work and just have a better quality of life. And then finally, conferring a survival benefit. This one, we have less good data, but this is the best data we have. The 5-ALA study, Tumors paper from 2006. You know, in a subgroup analysis, it did seem that these patients lived longer, although that wasn't the primary analysis of the paper. It did seem that that was the case if you did a bigger resection. And then there are some, I would say, level 2 studies out of Scandinavia proving the same thing in a semi-randomized approach. You know, you go to one center, you get a biopsy, the other center, you get an aggressive resection, and those people with an aggressive resection tended to seem to have overall better survival than those that just did biopsy. So when you're going to do cortical mapping, you really have to have a system, a program, a way of doing it. This is from a book I wrote a few years ago. This is the Rush Cortical Stimulation Mapping Protocol. You can follow this. It's, I think, a pretty useful protocol. Alternatively, there's a different protocol that just came out of Mayo Clinic, Florida. This was published last year. In reality, the difference between this one and this one is very small, in part because the Rush program, the Mayo Clinic group, there's been a lot of interchange. There's, I think, a lot of us have shared our ideas over the last 15 years, UCSF, other programs, and so on. And there's coming to be more and more of a consensus of how to do cortical stimulation mapping protocols. Besides the surgeon, the patient, and so on, the neurologists are very involved. The electrophysiologists are involved. You have to have an experienced neurology and electrophysiology team looking out for after discharge, monitoring the patient. The anesthesia team is really, really critical. An experienced anesthesiologist is critical. Some of the equipment, you can use a Phelan table like this here at Mayo Clinic, Florida. At Rush, we did not use a Phelan table. Phelan table is nice because everything is off of the patient. The mapping equipment, the stimulation mapping equipment has to be well organized. We use bipolar and monopolar mapping here. NeuroMapper, I think, is a real game changer. This is a great addition. This came out of the Medical College of Wisconsin. David Sabsovitz is our neuropsychology PhD here at Mayo Clinic, Florida. He is just a fabulous person to work with. Uses the NeuroMapper program. NeuroMapper it's an automated program showing naming protocols and other protocols. It tracks the data very, very carefully. It's reproducible, really an excellent protocol. I'm very impressed by the neuromapper. David Savzovich is a fabulous person to work with for us. This is something that I brought to Mayo Clinic, Florida. I've been using it at Rush for probably 5 years before that, and this is suction stimulation. Suction stimulation is actually FDA approved for things like thyroid surgery, and you're looking for the recurrent laryngeal nerve and so on. But it is used off-label in the brain. I don't really care what company you go with. There's a few companies that provide these, but this is a nice adjunct when you don't need a CUSA or Sonopet, and if the tumor is responsive to suction, it's a monopolar suction stimulator. You can set it at varying strengths. You can make it more sensitive or more specific, and it is something that we're using a lot of now. For bipolar stimulation, I think this is really important for everyone to understand. This box was created by George Ogerman, I think in the 1960s. And then it was put together by Radionics. There's a lot of knobs here, and by the way, they all matter. And you have to understand when you change or somebody else changes one of the knobs, you might not realize it. Somebody changed a knob. Well, it completely changes the parameters. So it's not just about, well, I'm going to give, 2 milliamps at 60 hertz. Well, I mean, it's easy enough to set for 60 hertz, and you might think you're giving 2 milliamps, but if you take a look at the box and you see that the range in the middle there is switched to the left, well, those are fractions of a milliamp. And in talking with George Ogerman a few years ago, that was actually used for spinal cord stimulation in research protocols, spinal cord stimulation in animals. So those are not milliamps. Those are a percentage of a milliamp. So you're going to have negative mapping every time if you have the range slipped over there to low. It has to be over to high. You have to check the pulse duration. If your pulse duration is at 2, you might be giving twice the electrical dose that you think you're giving, and you might give the patient a seizure. And then the pulse rate matters as well. So you have to think about this as an electrical dose rather than just we're giving 6 milliamps or 2 milliamps or whatever. The newer devices, the Natus device, which we're using because the Ogerman stimulator is no longer produced now. The Natus device is actually pretty good. But again, every time you have to take a look at it. You have to make sure that the settings are what you think they are, and then you can test it. And you can test these devices. If you're doing a temporal case, you can test the device on the temporalis muscle. If the temporalis muscle does not move when you put the stimulation at 10 milliamps, then something's wrong in the circuit. There's something wrong in the circuit. You have to recheck it. And then you have to make sure that you turn it back down from 10 milliamps because you wouldn't want to deliver that much energy to the brain. As far as mapping tags go, I mean, it was a convention in mapping for a long, long time. You can use clear ones. I've used clear. I've used these. My institution back at Rush, they made us tie them to ties so that they couldn't be lost in the brain. And then finally, I just gave up and I just stopped using them because I'm doing smaller and smaller craniotomies, more limited negative mapping techniques. I don't worry about the labeling anymore. Some institutions use them a lot. It's very difficult to keep them in place. For critical areas, it makes sense to maybe label them, but I tend not to do that anymore. I use a lot of ultrasound, intraoperative ultrasound. The high definition ultrasounds these days are spectacular. So it's a nice adjunct for a glioma while you're going after the glioma. The mapping is nice for the function. The ultrasound is really excellent for identifying the pathology. As far as awake surgery goes, it's really, and at least in my practice, is a sleep surgery. So I really only wake them up for the critical portion, for the mapping and for resection. It's very difficult for a patient to get through multiple hours of surgery. I tend to just let them sleep through. We give lots of local anesthetic. The scalp feels no pain if you do it right. Skull feels no pain. The dura does feel pain. It's nice to, at least if you're in the low middle fossa, to anesthetize the dura. If you're not near the low middle fossa, it's not so much of an issue. Propofol is commonly used for SED. We always preload with an anticonvulsant. I use a Mayfield clamp. I just don't like motion, but the patient should be facing anesthesia with slight neck extension just for better airway and airway access. So these are in my opinion, this is from that book that I edited. These are relative contraindications for awake craniotomy and uncooperative patients. I don't do kids. Extreme obesity and airway concerns tend to go together. Extreme mass effect, I think it's reasonable to consider staging it, taking tumor out, and then taking the pressure down and then bringing them back later. Or significant dysphagia. If the person can't follow your commands, if they're non-fluent before you give them propofol, they'll certainly be non-fluent when you've given them propofol. There's a variety of things that we do. Obviously, they have to have a medical evaluation. We try to control their ICP, positioning. We do preoperative evaluations. You might do imaging ahead of time. Image guidance we'll use most of the time. And then you really have to watch out for any sudden valsalvas. You have to be very, very careful about seizures. Seizures can cause a lot of brain shifting and increased ICP during surgery and bleeding. So cortical mapping can vary a lot by region. This is an example of this is an epilepsy cortical mapping case where this is at 0.3 milliseconds. So this is going to be 3 times the stimulation you'll often see. At 13.5 milliamps, at one example, there's no after discharge. At 3.5, there's an after discharge. Those are just different areas of the brain. Some areas more epileptogenic than others. So it's tough to standardize this. You just have to be careful as you're going. We wrote an experience in our subcortical cortical stimulation mapping parameters about almost 10 years ago now. And you'll see there's a lot of variation in where you're going to get stimulation activity from motor to sensory and where you're going to get after discharge. Hopefully the after discharge is going to come at a higher number, but that's not always the case. Sometimes people will have after discharge early. After discharge, by the way, is a localized regional seizure. So you have to take it very seriously. We give cold saline, we stop doing the stimulation, we let it cool down because that can turn into a generalized seizure, which can be very disruptive in the operating room. This is, I think, an important slide. This is provided to me by Marvin Rossi, one of my former epilepsy neurology partners. He had a PhD in neuroscience. He really was very sophisticated in the mapping parameters. And there's a lot going on here that we really don't think about or talk about that we need to. So we think about current and we think about maybe pulse width, but we don't, and frequency, but not much else. Take a look here. When you think about this, if you look at 0 here, and then there's a positive and a negative deflection because these are square waves. If you think about a 6 milliamp stimulation, there's a lot more going on than just that. There's a pulse width, and then there's a charge per phase. The charge per phase is really that area under the curve. That's what really matters, your charge per phase and then your charge density per phase. You have to think about it as an electrical dose that you're delivering. You're prescribing an electrical dose. So don't think about it just as current. You have to think about a current over time. And then as far as charge density per phase, it depends what you're using. If you're using a cylinder, that's a different charge density per phase than if you're using a disc versus a ball or whatever you're using for stimulation. That really matters. And then you have to think about charge density versus charge. And if you use a certain charge density and a certain charge, if you get above this blue line, you'll actually damage the brain. That area of the brain will be irreversibly damaged. So you have to be very careful about the charge density that you're giving. And then there's the frequency, of course, which I think everybody understands. And then there's burst duration. All of these parameters matter, and you have to check them and make sure that you're not altering these things. You don't want to go into and thinking that you're giving a very low current and then not realize that you're giving a very, very wide pulse width or a very long burst duration because you can give the patient a seizure. So in standardizing these things, this goes back to 2016. We had our first international brain mapping course. That was myself, Mitch Berger, and Hugh Defoe were the course directors. And we honored George Ogeman And George was there, and we talked a lot about these things. There were 250 people or so at the meeting, and we got all of the major brain mapping centers together. And most of these are glioma brain mapping, but some of them epilepsy mapping as well. And we talked about a lot of these parameters, and we helped to try to raise everyone's awareness and make sure that we're standardizing and keeping things safe. So I asked there were 9 major centers that were presenting at this. I sent out this survey, and I asked, how often are you using EEG monitoring for after discharge during cortical mapping? And the answer was almost always for most of them. And then Hugh Defoe does not use it, and Hugh doesn't use it because he never really goes above 2.75 milliamps, and he keeps all of his parameters very low, so he's less likely to get a seizure. And then in regards to negative mapping, if you assume your settings are at 1 millisecond pulse duration and a rate of 60, how high do you take it before you consider it negative? Most people take it to after discharge, but you get a variety of answers there. And I'll tell you, if you're taking your mapping up to 12 milliamps at 1 millisecond and at 60, you're very likely to give somebody a seizure. So we have to be very clear about that. So cortical stimulation mapping, just because you did it doesn't mean that the operation is going to be safe. It does not allow you to suspend the laws of neurophysiology. So when you think about this case, this is a 25-year-old male, had his first seizure, had his first surgery at an outside hospital. They did it asleep, no mapping. The surgery was stopped because of SSEPs diminishing. He had 6 generalized seizures in the next 2 weeks and presented for consideration of further surgery. So you see, they essentially got into the middle of it, took a little bit of tumor out, and then SSEPs dropped, and they stopped, and the patient continued to have seizures over the next few weeks and then presented for further surgery. And thinking this through, the SSEPs probably dropped because they had this large coronal incision here. And when you think about where they put SSEP leads, as soon as you open that large coronal incision, that SSEP lead is going to be moved, 4 or 5 centimeters away, and that'll give you an SSEP drop, as well as actually injuring brain. So that's probably where their SSEP drop came from. So we did this case with the patient awake, cortical stimulation mapping. But a couple of things to remember: you can't map, identify cortical areas that are critical or subcortical areas that are critical, and then just resect everything around them. If you do that, you've essentially created a cortical island, and guess what? It's not going to work. You can't resect around an important area and expect that it's going to still be connected to other things and work. And secondly, you can't map cortex, say it's eloquent and important, and then take out its white matter below it, because you're essentially just going to be disconnecting it and you'll end up with a major deficit. So it's important to keep that in mind. But at the same time, intraoperative imaging can also, you can't suspend the laws of neurophysiology for this either. So if you see that there's tumor in eloquent cortex and you've mapped that eloquent cortex, you have to respect that. You have to leave that alone. You'll see this resection in this patient's case. I had to leave tumor within the precentral gyrus leg area, because if I took that out, even though I can see it, if I take it out, the patient's going to have a major deficit. So how about we'll just do a couple of other fun cases. This is the insula. The insula is my favorite place to operate. The insula, 3-4 decades ago, was a no-go zone. It was actually Gazi Yazergil, who recently passed, who showed us that in most of these cases, insular gliomas are really just a massive expansion of the insula, and they will usually preserve important basal ganglia structures below, and they'll often go right to the line of perforators, the lenticular striate perforators just deep to them, and they usually stay out of the internal capsule. Now, there are cases where those rules are violated and you have to just stick to the anatomy, but in a lot of these cases, it's just a huge expansion of the insula, and you can operate in these cases safely. You have to be very careful at the very depths of the resection cavity. I tend to do these cases transsylvian rather than transcortical. I just do a wide sylvian fissure split all the way posterior. I identify M1, I find the lenticular striates anteriorly, and then I expose from the superior to the inferior circular sulcus, and then start the resection right about the area of the insular apex. For the most part, I'll do these cases. I'll resect the lateral portion of the tumor first with the patient asleep, and then I wake them up for the areas down here near the internal capsule and the lenticular striate perforators. When you see one vertical lenticular striate perforator, you have to stop because you're about to see a bunch more. So we typically, when we identify one, understand that the rest of them are right nearby as well. And I'll use a lot of monopolar stimulation to identify the posterior limb of the internal capsule, typically starting off with 500 hertz and about 10 milliamps. You can go up to 20 milliamps. I have never had a seizure with monopolar stimulation. I've been using it for somewhere around 10 to 15 years. Monopolar stimulation is very, very likely to be positive if you turn it up high enough. It's going to be less specific, but it's very likely to be positive. So if you take a look here, using the monopolar stimulation to find that posterior limb of the internal capsule right there. I also used intraoperative CT scan. You can see that glioma does show up fairly well on ICT. The advantage of ICT is it takes about 15 minutes to get it done. I now use IMRI for some of these cases. Some cases you don't need it. Some cases the glioma is very distinct from normal brain. But in those cases where it's indistinct, intraoperative imaging can be very useful, including ultrasound. Now we're thinking about bipolar stimulation versus monopolar stimulation. I've been using both my entire career, but was using mostly bipolar stimulation for, I'd say, the first decade. And then I've been using more and more monopolar stimulation for the reasons that I pointed out. When you think about it, we call it monopolar versus bipolar, but you know, because you know, in one you've got the two poles of your stimulator just millimeters or a centimeter apart, so all of the charge goes between those 2 points. In monopolar stimulation, you have a distant ground which you can put on the chest, you can put on the forehead, just anywhere on the body. So you'll have a cathode and an anode, and you can either do anodic or cathodic stimulation going one way or the other. You'll get somewhat different responses for each. But you also have to think about it as when you're doing monopolar stimulation, you're usually using frequencies of 250 to 500 hertz. So you have to think about it really as high frequency stimulation versus low frequency stimulation. With bipolar stimulation, you're usually at about 50 or 60 hertz. And then the intertrain rate is going to be very different. The number of pulses will be different. So that's the way to think about monopolar versus bipolar stimulation. So Lorenzo Bello, who I wrote this paper with when we're comparing monopolar versus bipolar stimulation, is really an expert in monopolar stimulation. I love listening to Lorenzo. He's pushing some interesting frontiers here. So less likely to cause seizures has been exactly my experience. More likely to be positive on motor and sensory mapping. That's also, I think, true. There's a lot of people talk about this rule of thumb of 1 milliamp of monopolar stimulation at 250 hertz. It will equal 1 millimeter of depth of stimulation. I think that is an oversimplification. It depends. It depends on directionality. It depends on what you're stimulating. Oftentimes, when you think you're stimulating white matter, there's gray matter in the cortex and in the sulcus nearby. So when you're thinking about, well, maybe 10 milliamps equals 1 centimeter penetration, probably an oversimplification, probably fails at the extremes there. So when you get to 20 milliamps, you're probably not at 2 centimeters. When you get to 3 milliamps, you're probably not, at 0.3. It's probably not that simple, but that's just a rule of thumb. So I do think, though, it is particularly useful for deeper structures, for internal capsule, for white matter. And you can use this with EMG monitoring. So if you don't pick it up clinically, if your mapping team isn't seeing something move, if you're using EMG, and even if the patient's asleep, the EMG will likely pick it up, and then you'll know that you're near that track. So how about monopolar for language mapping? This is something that Lorenzo Abello and a few other groups, a couple in South America, are trying this. And yeah, it works. It actually does work. It's probably less specific. It probably activates a larger area of cortex. So you might use monopolar stimulation as sort of a general sounding board to find a region that you want to hone in on with bipolar stimulation. Or we may find in the future that this is adequate and the way to go, as long as you have the patient awake and you're talking with them and making sure they're okay while you're doing the resection. So here's another insular case. If you take a look at this, believe it or not, this man had no headache. He had no behavioral problems, no speech difficulty, just had a seizure. And you see a case like this. Again, I tend to go transsylvian, wide sylvian split. The patient is not awake for that. You can see there's significant mass effect here. Wide sylvian split. Isolate the middle cerebral artery vessels. Go from sulcus to sulcus, the inferior circular sulcus to superior circular sulcus, all of the anterior portion of the tumor. And then I wake them up for monopolar stimulation of the posterior limb of the internal capsule, and also for white matter underneath the operculum. And again, here's a case where we used an intraoperative CT scan, and that showed a little bit of residual there down in the frontal lobe. And if you take a look at the MRI scan, it turns out that that was true. There was a little residual there, but you're able to find that lenticular striate line, stay out of it, identify the posterior limb of the internal capsule, monopolar stimulation. And the patient, this is the patient post-op day one, actually talking. I don't know if it's going to work here. It looks like it's not going to work as far as the video goes. But you'll find that the patient, if you're careful with this and you don't get into lenticular striates, and you talk to the patient through surgery, typically their speech is going to be intact. It may be slightly simplified right after surgery, but they typically get back to their baseline. And then if you look in the cavity here, you have to be very careful of the MCA branches going nearby. You have to treat them with great care. The branches on the insula themselves, however, can go. The central insular sulcus will usually have the central insular artery, but all the bypassing arteries to the operculum have got to be spared. So cortical mapping does not protect perforators. Now, but you can watch out for perforator injury with continuous observation during surgery. So this is another person, a different case, a little more frontal. You can see that this tumor, if you look at the axial, violates that lenticular striate line, so you have to be very careful of that. But again, transsylvian, asleep for the beginning of the case, debulking till the mass effect is done. And then when the patient is awake, then you approach that lenticular striate line in the posterior superior border of the insula, which is the most dangerous area. And you have to watch out for the retrolenticular perforating branches off of inferior M2. Those are going to the posterior limb of the internal capsule. So as you're resecting this, if you get into one of those perforators post-op, if you take a look here, you'll see a small perforator injury here. And we detected that because the patient started getting foot weakness during surgery. That was not internal capsule, that was actually a perforator injury. And then you can see what that looks like, the transsylvian approach here in the bottom right. Now, winding up here, so we have some time for questions. We just had a neurosurgical focus video session here, edition. We had a lot of submissions, some really interesting, innovative, new ideas in mapping cortical and subcortical. I want to point one of them out, and this is one by Linda B. This is, I thought, a really interesting application, and that is using monopolar stimulation in the posterior fossa to identify the transition zone between brachium pontus and the pons. I think this is another interesting application of mapping in the posterior fossa, which I personally had not done, but I think that that's a clever thing to do. So in conclusion, cortical mapping in well-selected patients can maximize resection and hopefully reduce tumor-related symptoms and possibly improve survival. Cortical mapping remains the gold standard for eloquent cortex and the subcortical tracts. But there is a lot more interesting stuff coming up, innovative stuff in imaging mapping and gamma frequency modalities that I think are improving and becoming more useful all the time. So thank you very much. Glad to take questions.
Thank you very much, sir, for this very wonderful and eloquent talk. Yes, sir.
Thank you, Rich. Amazing talk. I just had one question for you. Can you guys hear me okay?
Yeah.
Yes.
You know, I think I practiced many of the things that you just taught us and told us. And, you know, I've learned, you know, through the years that, you know, maybe we don't need to do awakes as often as we've done in the past. And I just want to get your thoughts. Two parts of my question. So that's part one. And then part two is, you know, we're trying to study the connectomics, some of these higher level orders and nodes in the brain. And I'm not quite sure we're quite there in terms of localizing that function during surgery, although there's some trials and studies being done with that. But I'd love to hear your thoughts on that.
Yeah, I'm selective about mapping. You know, I think you'll see there's a wide range of what people will do mapping for. There's a wide range of what people will do awakes for. For instance, I've seen people do awake mapping of right temporal lobe glioma, which I don't do. To me, if the critical structures that you're trying to preserve are really blood vessels, I don't need a patient awake for that. If the critical structures are so distinct from the pathology, like that cavernous malformation that I showed you, I don't need mapping to find that border. I know where the border is. I mean, it's abundantly clear. It's the hemosiderin stain, and you take out the pathology. So I'm selective about it. I showed examples of how, you know, if you're not putting the eloquent cortex at risk, you can get there a different way, you know, subtemporal or whatever. Go for it. I think that selectivity is hopefully, I think, becoming more common. And you're seeing more of a convergence. You know, it used to be there was an awake mapping group, and then everybody else who didn't do any of it. I think we're sort of coming to a consensus that there's a subgroup of patients where you have the option of, and then there's some patients who are just far too anxious to get through an awake case. There are some patients where there's way too much mass effect, where I'll just stage that case. I'll take out the 80% of the tumor that is not risking eloquent cortex and then bring them back a few days later for the 20%. When the mass effect is down, when I'm not worried if they have a seizure that there's going to be, you know, just mass expansion of the brain. As far as connectomics goes, yeah, I mean, when you think about it, it's a 3-pound organ. It's extremely expensive real estate. It takes 20% of the cardiac output. You know, you're not gonna have non-eloquent brain. All brain matters. All brain matters. And you know, I found that out in my epilepsy work. You know, you'll have subtle neuropsychological consequences from a right temporal lobectomy, but in reality, it's not life-limiting. So when you look at the connectomic stuff, yes, it's all connected. But I'll sometimes hear talks where somebody says, well, you can't take out the temporal pole because I see it here connected in the connectomics. You know, it depends. If taking out the temporal pole gets rid of their seizures, that's worth the trade-off. Everything's worth a trade-off. I mean, you have to think that through. But I would say that yes, selective mapping is my personal way of going about it. But you'll get different opinions about that.
So when we talk about brain tumors, we sometimes think about the functional reorganization that we may have, and also there are connection multiplicity and connection heterogeneity, and also the loss of connection. So how do all these things do you think matter when we are going to opt for brain mapping, and how can it affect our results?
I'm sorry, I didn't understand the last part there.
So when we are actually thinking about the presence of brain tumor, we sometimes think about, the functional reorganization that we may have, or exactly. So the loss of connections, and there could be connection multiplicity, there could be connection heterogeneity that's there. So how do you see all these things, and how does it all matter? And when we are actually thinking about the negative mapping, how much we should be confident that it is a true negative and there is no loss of connection, or if there is anything that is being really left in that negative space.
Well, I think we know that plasticity is more of a factor in younger people. So under the age of 7, plasticity is I mean, you can lose a left temporal lobe at 7, and your speech will show up in the other hemisphere. That's not going to happen in an adult. So plasticity becomes less of a factor the older you are, certainly. And when I think about, so if you do an operation on a glioma near a speech region or speech circuit, and the person has a temporary deficit, and then they get better a couple of months later, maybe that's plasticity, maybe that's an area that was manipulated that shuts down for a while and then becomes functional again. And then if you do mapping and then you come back a year later for an extension of a resection for glioma and find out that the area that was positive mapping for language now is negative, that may be plasticity. It may be variability of mapping findings. I think there's so much more that we don't know. I mean, I think that's a great area for study. And, I hope that we can capitalize on the brain's ability to use plasticity to improve function. And that of course goes for stroke and all sorts of other things too.
Sir, we have a few questions that are present that have been presented to us by the audience. So there's one question: whether it is navigation or cortical mapping or intra-op CT, it should give a good outcome up to grade 3 glioma. Epileptic focus is the rule. What is your comment? Whether it is navigation or cortical mapping or intraoperative CT, it should give a good outcome for grade 3 gliomas. Epileptic focus is the rule. What is your comment? I think this comment has been a little decomposed.
So I think what they're getting at is, there's
What
a
would be
variety
the
of different
outcome?
things. There's a variety of different things you can use, and you can
Yes.
use any of them, all of them. And depending on what's available to you and what you have experience with, I can tell you that the most recent generations of high resolution ultrasound are spectacular. So if you're looking for borders of a glioma, some of these, take a look around. I'm not going to talk about brands or anything like that because I think they're all getting better. But intraoperative ultrasound is probably the most underutilized tool that we have. Take a look at it if you haven't looked at it recently. It really does make a difference. And you can use it, 30 times in a case. It takes a minute to use it, and you have instant feedback. So I think that's something that's underutilized. And all of these are just tools. They're all tools that we have available to us to keep the operation as safe as possible.
Sir, this also gives rise to the question of the use of magnetic encephalography, which is quite, it's in the literature. People use it for epileptic surgery. And when we compare it with the fMRI, there is also lesser chances of the neurovascular uncoupling. So, how do you see MAG versus fMRI when you compare it, and how would you like to proceed in the case of brain tumors?
You said MEG?
Magnetic encephalography.
Yeah. I used MEG back in Chicago. There was a MEG machine we'd sometimes send them to. I can't really comment much on MEG. It's been years since I've used MEG. I think it's, those with more experience on MEG can give you a better answer.
Sir, there is one question. How do you modify your techniques for hippocampal gliomas?
Oh, well, so here's my thoughts on that. Neuropsychology matters, obviously, particularly things like, verbal memory. Those are important factors. But I'll tell you this, if a glioma has already taken over a hippocampus, there's no point in preserving the hippocampus. All right, there just isn't. Second thing, if a glioma has taken all of the surrounding afferent connections of the hippocampus, so if it's completely taken away the parahippocampal gyrus, and there's not a whole lot of point in preserving that hippocampus. So that's the way I look at it. If the hippocampus is already essentially disconnected, there's not a lot of reason to keep it. It's, it very well may just cause seizures for the person. But if the hippocampus and its connections are not involved in the tumor, then it's nice to be able to spare that.
That's excellent. So thank you very much, sir. Still there are a couple of questions in the
I think
chat
we're gonna
box.
have to.
Yes,
Well, I think Maria,
we are
the
good to
hour's
go.
up. We're gonna have to cut it off there. But Rich,
Exactly.
really enjoyed your talk. Thank you so much for doing this. And I'm sure this is going to be watched by others offline when it's posted to the website. So thank you everybody for joining us today. Thank you, Maria, for helping. Okay.
Thanks,
Okay.
sir.
All right.
Thank you.
Thank
Bye.
you. I guess Timothy will say a few words about the CME accreditation. Mr. Timothy, will you come forward for the CME accreditation guidelines, because this webinar is worth 1 CME credit.
So I will share the instructions for claiming CME again. I will also send them out. Please give me about till the end of the week to get everybody registered, and then you will receive a notification email from me with these instructions for accessing and claiming the CME.
Thank you very, very much. Sir, thank you very much again for this very excellent and very insightful talk, and for all the time that you give in such a busy day. So thank you very much, sir. Looking forward to inviting you again.
Right. Thank you.
Thank you very much, sir.